Good afternoon, everyone. My name is Ladi Kukoyi. I'm a psychiatrist and a family physician. I'm the chief of staff at the Birmingham VA Medical Center and a clinical professor of psychiatry and family medicine at UAB. I'm over here in a private capacity and not in my role as an employee of the VA or of UAB. And what I'm going to talk about doesn't necessarily represent the views of the VA or the United States government. So I'm going to talk about suicide. I'm giving this talk twice, two different talks. So the first half of my talk this hour is mostly going to look at a global view of suicide. And then if you stay for the second part, which I think I get a 30-minute interlude before, I'll talk about the United States, veteran suicides, and COVID and suicide as well. So that's how my talk is going to be divided. So this here shows you a graphic of, this is a couple of years old now, but there's suicides in the news every day. My wife sent me one last night of a newscaster in Texas who died suddenly. They didn't tell us why she died, but then the television station put up a sign saying, call the 1-800-273-TALK number, which tells you she killed herself. And the sad thing is her son died by suicide 2 years beforehand. So death by suicide is extremely complex, as you all probably know. It causes pain to hundreds of thousands of people. Each suicide is a tragedy, and we have data from the World Health Organization, and there's an annual study that's published in The Lancet every year, the Global Burden of Disease, that looks at the contribution of different diseases to mortality and suffering around the world. And from that, we know about 800,000 people die every year, and that's one person every 40 seconds. That's a lot of people. However, we do know that we can prevent many, if not most, suicides with timely evidence-based interventions. So, as I said, about 800,000 people die from suicide. That's twice the number from homicide. That's true in the United States too. That people don't think about that, but more people kill themselves than are killed by other people. And suicide is more common than homicide across most places in the world, often as much as 10 to 20 times higher. And you see some of that data. It is one of the leading causes of death in young people. In many societies, it's the second leading cause of death in young people, high school to college age children. 1.4% of global deaths in 2017 were from suicide. In some countries, that's as high as 5%, which is pretty high compared to the rest of the world. Suicide rates typically are higher the older you get. When I was a medical student and a resident at brand new faculty, the answer to the question about which of these has the highest suicide rate is always the oldest white male. Usually divorced, widowed, whatever. That's not true anymore in the United States, and I'll talk about that some. That changed sometime in the past 5 or so years, which means you can't just find the question, look for the oldest guy you can find there, and that's the answer. It's no longer true in the United States, but it's true across much of the world. Globally, the suicide rate for men is about twice as high as for women, and in some countries, the ratio is even higher. Suicide rates from firearms are particularly high in the United States. 60% of the deaths from firearms in the United States result from suicide, and you'll hear more about that later. And then finally, self-poisoning from pesticides have had a large toll, especially in low to middle income countries. So while in the United States, firearms is the biggest way, or one of the biggest ways people die, in much of the world where people don't have access to firearms and stuff, in countries out in Asia and the Western Pacific, pesticides are the #1 way people kill themselves. And where the epidemics going on in the world, pesticides or insecticides, rodenticides, things that they use that are easy to grab in agricultural countries. So it's fascinating looking at things globally. So if you look at suicides by age and income level, you see that most suicides in the world are in the poorer countries in the world, not the richer countries. But that's also because most people in the world live in the poorer countries. And annual causes of death worldwide shows you that suicide is number 10 or 11 around the world, and that's true in the United States too. The graphs don't look dissimilar. And the death rates of suicide, if you want to compare it, we usually compare deaths per 100,000 people because it's not that many. So you got to adjust it for population so you can compare. And around the world, globally, about 10 per 100,000 people die from suicide. And I'll show you a map that shows you what it looks like. Again, for many years, the death rate was such that the suicide rate in America was about 11 11.1, 11, and started creeping upward. Now it's 14.2. That's a huge jump from the time I started giving this talk like 15 years ago or so. Amazing, because I could just update my slides minimally and the answer would still be the same year to year. Now, completely different. The rates have accelerated, which is kind of scary in the United States. And around the world, in Eastern Europe, South Korea, Zimbabwe, Guyana, the rates are up to 20 per 100,000 people. And then in some parts of the world, like in North Africa, the Middle East, and some Mediterranean countries, is less than 5 per 100,000. So you can see there's a variation across the world in suicide rates. And this map here shows you the darker the color, the higher the suicide rate. So you can see the United States is about middle for the world. Up there around Greenland is the highest suicide rate in the world. And you can see some of the lower suicide rates right there, North Africa and places I mentioned. So how have suicide rates changed around the world over time? Well, since 1990, suicide rates have actually dropped in most places in the world, including in Europe and Asia. Other regions, the trend has varied more, and in the United States, it's increased. And you can see that from this graph, that the green, the one at the top is India. Suicide rates have dropped over time. You see the world has dropped from about 15 to about 10, and then the United States has gone up. Closer to 15 now. It was just a little above 10, now it's closer to 15. And the United Kingdom has dropped, and whatever that last country is, I can't see too, has dropped too. So the United States, of all the major countries that I pulled up in this comparison, is the only one that's gone up over time. The share of deaths from suicide tell us about 1.4% of deaths around the world were from suicide in 2017. And the next map I'm going to show you shows the variation in the proportion of deaths by suicides. At the highest end, 5% of deaths in South Korea were by suicide, while in Greece, it's only about 0.4%, Indonesia 0.5%. So there's like a tenfold variation from 0.5 to 5%, with the average about 1.4%. And again, you can see the darker color shows you the part of the world where the suicides form a larger part of the share of death. And this gives you, in a line chart, the rate of the share of death from suicide. You can see South Korea is by far the highest in the world. And then you can see Greece is way there at the bottom. The United States is just about average in the share of death from suicide. Looking at age as well, I talked about suicide being one of the leading causes of death in young people. It doesn't mean young people are more likely to die from suicide. It just means that older people also die from many things, but young people don't die from heart disease, they don't die from strokes, they don't, so they're going to die from accidents and violence, self-directed or other. And if we look at deaths in older people, you see that cardiovascular disease, cancers, etc. But because the number of suicides are high, these other causes contribute, so they have many things that can kill them, unlike younger people. And the next couple of charts and graphs I'll show you how suicide rates are broken down across the world. And you see, generally speaking, the older the age group, the higher the suicide rate, but not true in the US, as I've said, over the past several years. So over here, you see the death from suicide by age across the world from 1990 to 2017, and about 800,000 people die. And you can see at the top is the 70 plus years old, then the next age group, and then the youngest age group has the largest number of suicide deaths, but not the greatest proportion. And the US kind of generally mirrors that as well in this next graph. And if you look at the proportion of deaths around the world, it's the 15 to 49 age group that have the largest proportion of deaths, which is also true in the United States. So the death rate around the world, generally, the older you are, the more likely you are to be in a group that has deaths by suicide. So you can see the 70-year age group, then the 50 to 69, the 15 to 49. So the older you grow, generally, the higher your risk of death by suicide. The US, however, changed. You can see this doesn't, I'll go back so you can see. This is a straight line down as the age group goes up. But you can see the US, the 50 to 69 went past the 70 here, and we've got the 15 to 49 going up as well too. So the United States doesn't mirror the rest of the world, and that's a question that we have to answer. United States is, I believe, the only industrialized country in the world that's lost life expectancy over the past decade. We don't quite understand what's going on, but something is going on in the United States, and all this all add to it. So deaths by suicide are going up, deaths by overdoses, and deaths from some diseases we should have control of also going up before we even hit COVID. So all these things are telling us there's something wrong with our healthcare system, that we're not getting the outcomes. For being the richest country in the world, we're not getting the outcomes that you'd expect. We stand apart from the rest of the world by life expectancy going down rather than going in the right direction. And our suicide rate also is an anomaly with that. So if you look at the change in suicide rate in the US, you can see that the 50 to 69 age group has gone up the most over that time frame from 1990 to 2017. That's why they have the highest death rate now. And then you see 15 to 49 has gone up a lot. The 70-year group has dropped. So the reason why 50 to 69 has the highest suicide death rate in the United States is because the oldest group, suicide's actually coming down. So whatever we're doing or whatever it's intrinsic in them is keeping them alive better now. So they're no longer the answer to my question. Letter E, it was always E, 79-year-old guy who, so if we could figure out what's going on with those guys, maybe we could translate it to the younger population. And we've known this. We've known this for several decades now, that the suicide rate is going up with each successive generation that's been born over the past 4 or 5 decades, without good reason. So we need to understand and actually figure this out, because left at this rate going like this, it'll just keep going the wrong direction rather than in the right direction. I'd love to see it go back towards 11, which is the number I knew for like 10 years, or less than that sometime in my lifetime. But you can see, look at the rest of the world. Suicide death rates have gone down uniformly across the rest of the world. I'll flip back to the United States so you can see what the United States looks like. The only one that's really gone down is 70 or older. Everybody else has gone up. But look at the rest of the world. Every single age group is going downwards. So we're doing something wrong. And I'm not sure what it is. Maybe y'all can participate in dialogue with me later on as we think through what's going on. Again, this is during a period of relative prosperity and stuff in the United States. So think about what would happen now that we're going through a period of relative turbulence and chaos and upheaval, because those times generally don't go with good health news. Here's a chart that shows you what I've just talked about in a different way. That can see the 70 plus, the suicide rate, the change, and then again, across the world uniformly, it's the older group that's the highest rate. So as you go up from the younger age group, the rate goes up as you go up. And look at the United States. It doesn't look like that. I'm going to go back again so you can compare and contrast. See, very clear step-like progression as you go up. United States. So it's like the United States is on a different planet than the rest of the world with whatever it is we're doing or we're not doing. So just food for thought to think about as we make public health plans and take care of people who might be at risk for poor health outcomes. I'm going to talk about gender next. And so, as I said at the beginning, we know suicide is more common in men than women in all countries. And globally, rates are about twice for men as they are for women. And in 2017, and I'll show you in the chart soon, the death rate for women was about 6.3 per 100,000. For men, it was about just twice that figure at about 14 per 100,000. And this is true across every country. In fact, in my entire career, I think I've only ever seen a couple of countries where the ratio was different. And I think that's based on poor demographic data that you have, because no country should be that different than 99.99% of the world. And you see the ratio on the map and the graphs I'll show you of male to female. And the suicide rate for men in some countries is up to 10 times as much than for women, like in Eastern Europe. But in most countries, it's around 2 to 4 times higher, which is where the United States is at about 3.6. And then in places in South and East Asia, the ratio is actually pretty small, such that in Pakistan and Bangladesh, there's almost no no gender difference. And in India, the ratio is 1.4, in China is 1.6. And I can tell you, in all those countries, what they have in common is people use pesticides to kill themselves. Equal opportunity access. So there's no differential. The reason in the United States why men die from suicide more than women isn't because men make more attempts. Women actually make many more attempts. It's because women don't use guns generally to kill themselves. Men use guns. If you use guns, your chances of dying just went up significantly. 90% of attempts with a gun are fatal. However, if you use pills or whatever, I don't know, 10% of them are fatal. So that's a big difference. If women start using guns to try to die, our death rates will equalize between women and men, maybe go up, because women attempt suicide multiple folds more than men do. So here's a chart that shows you male and female suicide over time around the world. You can see Japan is up there. You see the United States, which is about average, and then the United Kingdom and Japan lower. The female suicide rate is down there for the United States. So the women aren't as elevated as the men are. And so again, my map that shows you the darker the color, the higher the ratio of male to female. So this doesn't look like the other maps I've shown. The dark parts on the map are not where they were in the other pictures. And you can see the male to female ratio gap of suicide rates. UK and US are about the same. So the US is actually tracking for once in all these different data points I've shown you. And you can see Japan, the world, China and India around this. The United States and UK have an elevated male to female ratio compared to the world average. And then if you look at death rates by gender across the world, they've dropped across the world. The United States hasn't, of course, but you can see male and female dropping. It looks like the same slope, so the ratios seem about the same. You see the United States, this is also another map that shows you how it's changed, the percentage drop. So it's dropped for females about 50% it looks, and for males about 30% over the past 30 years or so. So that's good news. But look at the United States, it's not dropping. You can see the male rate has gone up and the female rate has gone up, and so together they've gone up slightly. And look at that, the female rate has accelerated skywards. So even though the male suicide completion is about 4 times that of females, the rate at which the females are going, over time, it will catch up with the men if it continues unchecked. So the fastest growing population at risk of suicide is the woman in the United States. Fortunately, they started much lower than the men, but you can still see that's a pretty sudden acceleration. That's 15% increase. Men have only increased about 1 or 2%. So the increase in our suicide rates seem to be driven, generally speaking, by increase in female suicide rates. So something to be mindful of. So globally, methods of suicide, and I've talked about this some, that firearms are one of the most common ways. They're responsible for about 8% of global suicide deaths, but in some countries they play a larger role, like in the United States. And the map I'm going to show you next will show you by darker colors where the higher percentage of firearms are. So United States, there's over 6 deaths per 100,000 from firearms, which is over 10 times greater than many countries across Europe. In the UK, it's 30 times higher deaths by guns in the United States than the UK. But of course, we have many more available firearms. And 60% of firearm deaths in the US are from suicides. And so you can see the United States stands out for being very dark red in the picture. And if you look at the world, the United States is only about 4% of the world, but that's 1/3 of the deaths by firearms from suicide. Pesticide poisoning is another globally common method, and we see this paper here that estimates that about 30% of suicides globally were the result of pesticide poisoning, mostly in the low to middle income countries. And over the past 50 years, an estimate of about 14 million people have died from self-poisoning, and that's more than the death toll of World War I, and approximately half the number killed from HIV/AIDS. So this is a public health issue that probably most people don't recognize. And you can see in this chart that shows you the Western Pacific is by far the largest place where people die from pesticide poisoning. And when you come across, you see it's not that big a problem in Europe or in rich countries or in Africa or the Mediterranean or the Americas. So lots of attention has been paid to pesticide poisoning, and 1 in 7 deaths are from pesticide poisoning around the world. And even though there have been restrictions and banning of pesticides in many of these countries to reduce how much is available, and suicide rates of pesticides have declined in recent years, they are still high, higher than we would want to be. So I want to talk some about global risk factors for suicide over the next part of my talk, and walk my way through this and talk to you. So first thing is mental health. I don't need to tell you that. The biggest recognized risk factor for suicide is mental health. It isn't the only one, but definitely is an important one. So depression and mood disorders, most of us know depression is a big contributor. Mood disorders are also another contributor, and this study I'm going to talk about tries to quantify it. The estimates vary across different studies, so the number doesn't really matter because you get quoted different kinds of numbers, but the most important thing is recognizing that untreated mood disorders and really any psychiatric disorders, any DSM-5 psychiatric disorder, including what we used to call Axis 2 personality disorders, all convey increased risk of death by suicide. And so they found in their sample 98% of those who died by suicide had a diagnosable mental disorder. And they used all diagnoses in there, not just Axis 1, but a wide spectrum of diagnoses to get to that number. And I'll show you the pie charts in the next slide to tell you what they did. So the left chart was people who died by suicide and had been admitted to the psychiatric hospital. That's the psychiatric inpatient population. And the right chart is people who died by suicide but had not been admitted to hospital. So they're labeled general population. They're really not, but they're people who died by suicide out there. And so 2 points that I want you to remember as we look at them. One is mood disorders, especially depression, account for the largest share of diagnosed disorders and suicide cases. So that's consistent with what we know, especially for those who were diagnosed without being admitted to the hospital. So when people die at home, mood disorders likely play a large role in that. Second is suicide is often associated with a variety of mental disorders. So attacking depression or mood disorders alone is not enough to stop it, because other mental illnesses also contribute to death by suicide: schizophrenia, bipolar disorder, borderline personality disorder, and so on and so forth. And so you have to have different therapeutic approach, because you can't just have one approach, because the reason why the person ends up dying by suicide is related to the specifics of the underlying disorder and the confluence of factors around them. So you can't just have one blanket approach. So you've got to think about how you can address it individually. So on the next slide now, you can see the two bar charts, and you can see how it shows DSM Axis 1 diagnosis: adjustment disorders, anxiety disorders, psychotic disorders, organic mental disorders, personality, schizophrenia, substance-related mood disorders. So if you use the entire spectrum of DSM diagnosing, virtually everybody can be diagnosed. If you're more conservative and just stay with the major Axis 1, the numbers of diagnosable disorders begins to drop, such that when I gave this talk 2 years ago, the CDC was estimating about half of the people didn't have a diagnosed mood disorder at the time of their death, which could mean one of a couple of things. One is they hadn't gone to get diagnosed, or we're getting a different phenomenon in the United States, which is leading to other things causing suicide beyond psychiatric illness. So something worth investigating further with studies and learning more, because the United States, again, is marching a different path than other countries. So I think it's worthwhile putting in the money to try to understand what's going on, because without understanding what's going on, it's hard to stop what's going on. So economic recessions are another big contributor to suicides across the world. And there's several studies that have looked at the correlation, and it kind of makes sense intuitively that if people are unemployed and they're overwhelmed with bills and stuff, you can see some people getting hopeless and despairing and deciding to die so as not to be a burden on their families. So one study here looked at Taiwanese mortality when there was the Asian economic crisis, 97 to 98, and looked at suicide rates. And I'll show you what the graphs show, but in some countries, notably Japan, Hong Kong and Korea, the male rates in 1998, right as the crisis started, rose significantly, which makes sense. Female rates didn't rise that much, which again makes sense. It tells you the men were affected by the economic crisis. You did not see the same patterns in Taiwan and Singapore, where the economic crisis wasn't as big. So it gives a credence to the fact that the bigger the insult to the economy, the more likely you are to see rise in suicide. Other studies found similar things, including in Europe right after the 2007-08 crisis, and I'll show you that. So the red lines show you when the crisis was, and you can see right there, the slope goes up in virtually all these countries right after that. So it shows you they had the crisis, except for, you see, Singapore didn't really change that much. And yeah, Singapore didn't really change that much. Taiwan changed a little, but not as much as Japan and South Korea clearly were affected by that. In the European Union, the inflection point there, 2007, is when the Great Recession happened. And you can see again, suicide rates went up at that time. So there's also data that says rising unemployment correlates with suicide increase. And most of the studies focused on patterns on specific events in particular countries or regions. However, more comprehensive studies using cross-country data over several world regions and over longer time windows have found similar results. So recently, North and Co. retrospectively analyzed public data for suicide, population, and economy over the 63 countries in 4 different regions from the period 2000 to 2011. And the data also corresponds with other data that says rising unemployment is linked to rise in suicides. However, it wasn't linear. The correlation was stronger in countries that had a lower rather than a higher crisis unemployment rate. So what that suggests to me is if your country was already doing well, having a major crisis where lots of people lose work is more of a shock to the system than a country where people are already poor. So more people being poor, they're already used to being poor. So the effect on their change in life-changing status isn't quite the same. So the psychological effects and the drive to die by suicide isn't quite the same. So that's what that suggests. Something else that correlates with suicide is gun prevalence. And the United States is the leading example for the world. So almost half of all suicides in the United States are by firearms. In most other countries in the world that are rich, firearms only account for like 4.5% of all suicides. So the United States firearms account for 10 times as many suicides as they do in most other industrialized countries. And I'm going to show you a scatter plot from a study that looked at the relationship between firearm prevalence and suicide in a sample of all United States over the years 2000-2009. And here's what it is. This is a scatter plot. It's pretty straight linear correlation that the more guns the state has, the more people die from firearm. So Alabama is somewhere in the middle. So if you're looking for Alabama, just somewhere right in the middle. You can see Wyoming, Montana, Alaska, pretty big expanses of states with people up there that have the highest rates there. So, but the more firearms in the household, the more likely people are to die by suicide. Daylight. Some people know this, but most people don't. So let me ask, I have a live audience of a few people. Unless you read ahead, so don't read ahead. So let me ask you, when do you think the time of year is that people are more likely to die by suicide? Or what have you heard? If you know that, what have you heard when you were gonna guess? When do you think people would kill? Yeah, but that's wrong. I've heard that my entire life. That's wrong. It's always been wrong. It's never been true and never will be. And I spend a lot of time correcting that the answer is when it's summertime, spring. It's scary, but it's true. So think about it this way, and I'll go through my slides. Think about it this way, that when it's dark outside and it's cold, do you really feel like getting up and getting out to go do anything? Okay, so you have all those feelings, but now the sun comes out and you have a little energy to go out. Now you could see how nothing's really changed. You just have more energy that you might be more able to carry out what you had in mind. So that's how we think about it, but it's never been winning. In fact, some of the lowest times for suicide are the times people tell you are the bad times. So when you hear people tell them, you can go back and say, that's actually never been true. You can do Mythbusters, Google it. It's never been true. Maybe someday it'll be true because it kind of makes sense. People are lonely around the holidays, people do that. No, it's never ever been true that I found in the literature. So in many countries, if not most countries, spring and summer, higher suicide rates. June, July, August, scary time. We don't do campaigns around that, never. So that's a public health message I want to get across. That's when people can get out and stuff. Maybe that's when you realize, I thought things were going to be better when the sun was out. I thought it'd be great when and you realize it's never going to get better. You know, you get those thoughts, and that's when people get sad. Versus when you're in there saying, well, it's only this way because I'm inside. In a few months, it'll be all good. So a message to remember. Contrary to the common belief that suicides peak when nights are longest, many countries around the world, even though most countries, show spring and summer peaks in suicide. So remember that when you start worrying about folks. So I'm going to show you a nice little bar chart that looks at this in Greenland. So Greenland has the highest suicide rate in the world. You know, Greenland has weird months of only daylight and then months of no light. And so Bjorksten looked at the rising latitudes of Greenland in the sunny months. They found that suicides were more concentrated in the summer months, north of the Arctic Circle than south of it, and most concentrated in North Greenland, where 48% of suicides occurred during constant light. And so here is the data that helps with that. So the months that have the highest peaks there, as you can see, June, July, August, those are big months. So yes, so contrary to what you might have heard, winter, not in the northern hemisphere at least, winter isn't when most suicides tend to occur. There's peaks in the daylight period of hours. Divorce laws, that was a new one to me as I was reading through this too. So this is the value of looking at data globally versus just narrowly. So when women are trapped in relationships that there's no way out, you can imagine how it's easy to decide, I'm going to drink that pesticide, I'm going to take my pills and stuff because he abuses me every day and I can't get out. And allowing there to be the potential and opportunity for women to be independent by value of liberalizing divorce laws such that the woman doesn't need her husband's permission to get a divorce actually reduces suicide rate. Amazing. It's amazing. So when you look at suicide, not just as an individual thing, when you look at suicide, not just as a mental health thing, but look at it from a public health stuff, there's lots of things, there's lots of laws, there's lots of policies, there's lots of things we do that can make a difference in people's lives and align women, especially in countries where it's harder for women to be economically independent. We all know, still in the United States, as rich and free as we are, women don't make as much money as men. Women don't have uniformly the same opportunities as men. And so think about, multiply that to countries where women don't even have the chances they have in the United States. How hard it will be if your life is completely dependent on what your husband says. You can't go anywhere, you can't do anything. So the ability to give women the chance to walk out of that marriage that isn't working for them reduces their need, their desire to get out another way, right? Because people use suicide as a method of ending pain or saying, I want to get out. So if you give people a way out, then they'll take that option. Because by the time people choose suicide, it's usually because they don't think there's another way out. So, and Stevenson and Wolfers looked at variations in the United States. They actually used United States data to look at states when they changed divorce laws to allow unilateral divorce, so you don't need the other spouse's permission, to see what the relationship between the time when the state made the change and suicide and homicide rates for spouses. And it's amazing. You look at that, okay, kids younger than 10 don't get married, so there should be no change, right? That's a good thing. Kids younger than 10 aren't getting married. And 10 to 14 too aren't getting married. But you start looking from 15 to 19, not much of a change because not too many people are getting married at age. But look at from 20 to 24 all the way down, 25 to 34, 35 to 44, 45 to 54, 55 to 64, 65 to 74, right there. That as time goes on from when the laws were changed to allow unilateral divorce, the suicide rates in women dropped on the side. That's fascinating. Something, again, you don't think about, but those are things that can be done globally. Something else that affects suicide that I'm sure many people have heard of is the media coverage of suicide. Suicide is contagious in a way that we don't quite understand, but we know that if somebody dies in a high school, chances are you'll have several attempts in that high school. If it's a small town, you have several attempts and you'll have several deaths during that time period because it's like an infectious, it's a public health issue. So if you get nothing else from my whole talk today, is that suicide is a public health issue. Public, all of us, and we have to treat it as such. And the same principles that we're using to address the public health emergency we're in with COVID, some of those same principles apply. It's all of us together, taking the right precautions, being there together for one another. So when the media publicizes suicide in a way that doesn't give it context, it increases the risk of other people dying by suicide. It's like movies that glorify violence that don't give you the context around it. So kids grow up thinking it's kind of cool. I want to be like Rambo or whoever, stuff like that. But being able to show the damages, the effects of suicide on the people left behind and the rest makes a difference. So Gould and colleagues found lots of references from the literature on suicide clusters that support the fact that suicide is contagious. And Stack in 2003 looked at 293 findings from 42 studies and concluded that specific media content makes a substantial difference. That is, studies showing the effect of either an entertainment or political celebrity suicide story were 14.3 times more likely to find a copycat effect than studies that did not. And studies based on a real as opposed to a fictional story were 4 times more likely to uncover a copycat effect. So as a result of this kind of data, the World Health Organization and the American Psychiatric Association have developed guidelines for the media on how they report suicides. Unfortunately, I can tell you, as someone who watches the news and stuff, they do not follow through with that. The only concession they usually make is to give you the 1-800-273-TALK number. Everybody does that consistently, but the rest of the guidance about not talking exactly about the method the person used, because people don't really need to know that, not making it sound like it was a cry for help or no choice, but rather talking about the effects it leaves on the family they have been, talking about the pain. Let people see the reality of that. That makes a difference, because when you see that, it makes you think twice about, look at the family they left behind. Look at the ones they're never going to see grow. With that kind of conversation, you don't see it as, oh my goodness, Kurt Cobain, he went because he couldn't take, you know? So the media have a role to play in helping us with this scourge, and hopefully over time, we rely on less sensational headlines and actually try to do responsible reporting. So data from Austria showed that repetitive reporting of the same suicide and reporting suicide meets were positively associated with a higher suicide rates. But coverage of positive coping in adverse circumstances, that is, for example, somebody had suicidal thoughts, but they did not attempt to die by suicide. That helps keep people alive, because then you're telling them a message that while many people may have thoughts of suicide, and a lot of people do, most people with thoughts of suicide don't end up dying by suicide. This is how people survive. This is how they seek help. Emphasizing that fact that there's hope, there's a way out, and there's things you can do, you can seek help. That kind of message is a good message, but that's not the message that sells the headlines. And so they have a hard time selling that. But if we can be responsible with reporting suicide and how we communicate it among ourselves, it will help prevent it from being contagious. Alcohol use is something else that's linked to death by suicide. In the US, in 2007, alcohol was involved in approximately 1/3 of reported suicides. And you can think of how alcohol might do that. People drink to loosen inhibitions. You know, like people drink when they want to summon up the courage to go talk to a girl or to go out and do something. So when people are trying to make a final decision, you can see them drinking, so it's easier for them not to feel the pain or to think about what they're doing. So you can see that. Also, we see people that are drunkicidal, which is they drink and they're not really in control of what they're doing, what they're saying, and their actions, and sometimes they end up killing themselves, whereas if they were sober, they wouldn't have. Alcohol generally doesn't help people who are struggling do better. It interferes with your ability to make good decisions. Just like you tell your kids, don't drink and drive, don't drink and go out to that party. Alcohol just gets in that part of the brain and loosens your handbrake just a little bit more, and things that if it wasn't there, you mightn't do, it'll let you do that. And there's lots of studies that have shown relationships, mostly male, but the more alcohol is drunk in the country, the higher the male suicide rates. Russia being a prime example of that. So summary of some of the evidence, as I get to the end of this part of the talk, is I took a chart from a World Health Organization publication called Preventing Suicide, a Global Imperative. It summarizes the key risk factors for suicide and their relevant interventions, and the message is clear. Globally, to prevent suicide, we need to have interventions from the universal to the individual level, because suicide is a very complex public health issue. One size fits all is unlikely to work. So I'll go through this chart briefly with you all. So health systems, if people don't have access to health systems, then they won't be able to be treated for treatable mental illnesses. That's a barrier that we can deal with globally. Society, access to means. If you don't have a way to kill yourself, then you won't die. It's a myth that most people will just postpone and find some other way to die. They've done studies of people in San Francisco, Golden Gate Bridge, of survivors. Some people have survived, and they'll tell you they wish they hadn't done it. And there's videos out there, there's great movies that tell you that the one guy who's made his entire life since then telling the story talks about the first thing he thought of as was going on, like, oh my goodness, I made a mistake. And he was glad he survived. So now he goes around trying to stop people from doing that. Because as I say, someone said it before me, but suicide is a permanent solution to a temporary problem. It's, you know, you don't see a way out. So it's usually a crisis, a momentary crisis that overwhelms your ability to cope. If you can separate people from something they'll use to end it right there and then, the crisis passes and they can go on. So that's the biggest reason why means restriction is a big deal. And I'll talk about that more in the second half of my talk. Inappropriate media reporting, something else we can do something about. Stigma. In many countries around the world, in many cultures, in the medical culture, asking for help is seen as weak. Because lots of people, lots of doctors I know, lots of nurses, they won't admit that they have a mental illness, that they need help, because we're supposed to be caregivers, we're supposed to be strong. We're superheroes. Heroes work here, right? So that's how the hero goes until the hero dies. And then everybody goes, I should have said something, I should have known. So those are some of the things there. Community, war, disaster, conflict, stresses of acculturation and dislocation with immigration and societal upheavals, discrimination, trauma, relationships, sense of isolation and lack of social support, relationship conflict, discord or loss. And then on the individual level, people with previous suicide attempts, mental disorders, alcohol use that's harmful, job or financial loss, relationship stress, hopelessness, chronic pain, family history of suicide, genetic and biological factors. That's a whole bunch of things you can see. So there's many targets. And so it's going to be important to put in a lot of money and effort, which we're not doing as a globe, to try to attack some of these things. So mental health policies that are better, that provide access for people who have the need, particularly the poorer people, because they're the ones, I mean, finding a psychiatrist is a pretty hard thing in the United States. In Iowa, where I trained, over half of the counties didn't have a psychiatrist. I bet Alabama isn't that much different. When I left California, many of my friends were taking only cash-only patients, trying to find a psychiatrist, like, they only take cash. Only rich people can pay cash. And so many of the people who need help the most won't have access to ready psychiatric care. That's a problem that we've got to solve in the country. Policies to help reduce the harmful use of alcohol, to increase access to healthcare, restricting access to means, helping the media to report more responsibly, on raising awareness about mental health, substance use disorders, and suicide, interventions for vulnerable groups, minorities, people of color, indigenous people that have faced barriers over time that are institutionalized in the way many rich countries have developed. Training gatekeepers, crisis helplines, follow up on community support, making people connected. The more connected we are, the more likely we are to have a reason to live. Assessment and management of suicidal behaviors, making sure clinicians are trained and adequately responding and teaching people how to cope when they have these thoughts that are so overwhelming, these feelings, these emotions that make it seem like you can't go on another day. How to say the right things, how to help them work with the right thing, to give them just another second, just another minute, just another hour until that urge goes away, and then they can start all over again. And assessment and management of mental and substance use disorders. So, to summarize this part of my talk, Suicides take a high toll. Over 800,000 people die from suicide every year. Second leading cause of death in 15 to 29-year-olds. There are indications that for each person who dies of suicide, more than 20 others have attempted suicide. That's a lot of people. Suicides are preventable. For national responses to be effective, a comprehensive multi-sectoral suicide prevention strategy is needed. Restricting access to the means for suicide works. Effective strategy for preventing suicides and suicide attempts is to restrict access to the most common means, including pesticides, firearms, and certain medications. Healthcare services need to incorporate suicide prevention as a core component. Mental disorders and harmful use of alcohol contribute to many suicides around the world. Early identification and effective management are key to ensuring that people receive the care they need. Communities play a critical role in suicide prevention. They can provide social support to vulnerable individuals and engage in follow-up care, fight stigma, and support those bereaved by suicide. And here are my references. Let me stop and take questions, and then I want to start the second part of my talk and do 10 minutes before I take a break, if that's okay. So are there any questions?
One of the things you had said was about how the rest of the world, their rates are declining.
Yes.
And while we have most money and all this stuff, ours is increasing.
Yes.
We talked about many things that we could do, but what would you say is one of the most important things that we can do as a society to help go the opposite direction that we are?
The easiest thing we can do, but the hardest thing we can do, because everything in the United States is very political and partisan now, so it's the easiest, but it's also the hardest. I say this all the time. So I say this as an individual, not representing anybody, is to make it harder for people to have access to firearms. That one thing, even if you did nothing else, since we know that 90% plus of suicide attempts by guns kill the person. And most people who use guns use it to kill themselves and others. That's important. Twice as many people kill themselves with guns than kill somebody else. I don't think people quite understand. That's amazing magnitude. So even without being smart or being a genius or doing anything else, if we did that one thing, we would drop suicide rates in the United States to where the rest of the world, without doing anything else. But that's also the hardest thing to do, because people interpret firearms, it's part of the Constitution, and people see it through a political framework. I'd urge people to see it through a public health framework, that if you know that you're more likely to kill yourself with a gun than to kill somebody else in self-defense, maybe it'll change the way you think. And think about family and friends you have, and think about kids who may have stumbled upon that. I mean, how often do we see on the news here in Birmingham about people, 2-year-old shot to death or 4-year-old? So yeah, if there was one thing that's the easiest but the hardest because of the politics, that's it. A second close to that would be we need to spend more money on suicide prevention. We spend more money on every single thing else in this country than on suicide prevention, everything else. And that's pretty sad. I'll show you some numbers as I get into the second half. It's pretty sad and pretty scary. Mental health, suicide, depression, don't get a lot of money. Parkinson's gets more money, and there's nothing wrong. I mean, important stuff. Breast cancer, important stuff, but I think suicide is just as important too. I think the effects are such. So as a society, as a nation, as a globe, we haven't decided that we want to make this the priority we need to make here. We want to relegate it to a mental health issue. It's easy when it's a mental health issue because it's their job, versus it's a public health issue. It's our job. When it's our job, that's a lot harder. But when it's their job, we just need to get more psychiatrists, more stuff. We're never going to have enough psychiatrists or mental health workers to deal with this. All of us as a society, all of us as our brothers and sisters keepers, have to play a role in changing the tide of this.
We're going to have a two-part. So with we need more psychiatrists. What can we do, one, to help fix the stigma? Because there's absolutely a stigma with getting help. And then when you're talking about a lot of those that are taking all cash, why?
Okay, good questions. Let me start with the all cash. So the way our healthcare system is, cognitively based medical specialties, ones where you talk to people, and I have two of them, family medicine and psychiatry, get paid lower than procedurally based stuff. Invasive surgery, cardiology, and stuff like that. There's a magnitude of difference of hundreds of thousands of dollars. You go to medical school for the same period of time. You do residencies for about the same period of time. They may do a little longer, yet they end up making hundreds of thousands of dollars more than you do. At that, over the course of 30, 40 years, that's tens of millions of dollars potentially. You can easily begin to see why fewer people choose to go into specialties like psychiatry or stuff than would want to go into surgery or cardiology. So many people that have mental health problems can't afford the payment. Just like children don't have money, right? Children, it's the parents that have the money. So if you take care of children or you take care of patients with mental illness, which is besought by stigma, and I'll talk about the stigma, that means you're kind of resigning yourself to making less money than other people might do. And over the past 15, 20 years, there's been a movement in the cognitive aspects of medicine, again, in the two houses I belong to, family medicine and psychiatry, for concierge medicine, where they charge a retainer and people pay. I mean, on many of the doctor listservs I belong to, lots of people keep advertising because doctors feel overtaken by the forces of society, where there's so much paperwork with insurance and reimbursements have continued to drop and overhead continue to go high, that people are trying to get control back of why they went into medicine. And having a cash-only practice means you don't have to do what the insurance company tells you. You don't have to prescribe the drug the insurance company tells you. You don't have, because there's a lot of that really rubs at doctor's craw. When I was doing my residency training, again, I'm a family physician and a psychiatrist. If I came down to the ER for any of the other specialties I covered, because I covered every specialty in my family medicine rotation, never once did I have to call an insurance company. But if I came down for psychiatry, I always had to call the insurance company to get permission to bring someone in the hospital. Demoralizing. And then they'll turn you down too for somebody who I think is suicidal. It was just the most demoralizing. And then on the ward every day, I had to get on the phone with the insurance company to explain why the patient had to stay in the hospital. Those are the kinds of things that make doctors go, I don't have to deal with this crap. I'm going to do something else. So that's part of the challenge there. The stigma has existed since the beginning of time, and it's probably going to be here till the end of time. What we can do is to do what we're doing now, to know what the facts are, to avoid the myths, to call it by name, to identify it, name it in daylight. That it's not some mysterious thing. Just like COVID, I tell people there's a lot to be scared of about COVID, but it's not some mysterious thing. We know how it spreads. We don't know everything about it, but we know enough that we can keep ourselves safe. The suicide is like that too. Mental health is like that too. That it shouldn't be relegated to a corner of the room or to special people or to special hospitals or stuff. It should be in the house of medicine, because I've never seen a person with their brain outside their body walking. It's all together. So, but we've created this house where we've divided that part of the body. So all of us have to engage by treating psychiatric patients the way we treat all other patients, because the reality is psychiatric patients have more medical problems than other people. So they are your regular patients. It could be any one of us. And you know, the statistics are like 1 in 4 Americans has a psychiatric problem. So statistically speaking, at least one of us in this room does. People watching this, at least one. It's us, but people hide it so well. To be a doctor, it's so punitive that in many states, if you tell them you have depression and anxiety, you now have to report things that make it harder for you to keep your license or to get liability insurance and stuff, which dissuades doctors from seeking help. That is just horrible. This is the house of medicine itself too. We haven't even gotten past that on our own. So there's a lot. It's ingrained in our systems. And so it's one of those, we have many structural issues we're talking about in the United States right now. That's one of them, discrimination against people with mental illness. Did you have a question, ma'am? Okay, let's see, what time is it? So, okay, let me just do a quick 5 minutes and then stop there. Okay, so right here, showing you just some basic facts and figures that preface where we're going to go to the next when we come back. So suicide's 10th leading cause of death in the United States. On average, about 132 Americans die a day by suicide. 1.4 million Americans attempted suicide. So you see the number of people who attempted compared to people who died. And 90% of those who died had diagnosable mental health, and that's the narrow axis 1 diagnosis. Men died 3.6 times more often, and women were 1.4 times more likely to attempt suicide. So you see, even though women attempt more than men, men die significantly more than women do because they use guns more often. 48,000 or so Americans died by suicide. is the second leading cause of death for the younger population, fourth leading in the 35 to 54. And for veterans, it's 1.5 times higher for veteran males than for non-veteran males, and I'll talk about that too. And almost 1 million years of potential life lost to suicide before age 65. And firearms account for about half of all suicide deaths, and the cost is about $69 billion back in 2015. About 10% of Americans have thought about suicide, and 54%, more than half, have been affected by suicide. And the next picture is a map of the United States, and it shows you where different states are. So Alabama is right in the middle of the suicide rate. So not good, not bad, just is. So I'm going to leave this here as the last slide. More and more Americans are dying by suicide. What are we missing? Thank you. I'll be back after this break. Yes. Okay, so welcome back for part 2. So I ended with this slide, saying more and more Americans are dying by suicide. And what are we missing? As I showed you in the first half, if you look globally, the suicide rates for much of the rest of the world, definitely the richer part of the world and even the poorer part of the world, the rates are going down, but the United States is going the other way. And the numbers that died in 2018 was up by about 1,000 from the year before. And while the increase is small, it's a continued increase in deaths over time. Since '99, the suicide rate has climbed about 35%. And only 2 other of the 10 leading causes of death was there an increase, and that's in suicide and influenza pneumonia. So even though we know more about suicide, and hopefully I think there's less stigma, there's only theories about why suicide death rates continue to go up. Lack of funding is clearly one of the things there. So the amount of money for funding suicide lags much of the things. We only spent $103 million from NIH on suicide prevention in 2017, and in 2018 went up to $147 million. Breast cancer kills only a few thousand more people than suicide, and it got $689 million. You can see the disparity in spending. And if we're going to tackle a medical problem, the funding to understand the epidemiology and to be able to identify the causes and attack them is really important, and that's not tracking. There's also the context, the societal context in which things exist, and over the past several months, we've seen the news. We're alive and watching what's going on with our country right now, and it's kind of hard to separate the suicide rates from everything else in society. So one study, for example, says if minimum wage went up by $1, it could reduce suicide rate among workers with a high school degree or less. So meaning that there are things we can do to affect suicide rate that are related to governmental policies that don't necessarily affect the individual, but affect the universal structure in which we all exist, which is the slide from the World Health Organization that I showed you all to show you all the myriad of ways in which suicide can be affected. So within the United States, the cultural context of suicide is important to understand that there's no one single explanation for suicide. There's no single path to or away from suicide, and there's no single medical cause, ideology, or treatment or prevention strategy, because suicide is very, very complex. It's like cancer. You know, when we say cancer, cancer is like 10,000 different diseases. Suicide is probably the end result of a myriad of different things. So different interventions for different specific problems that get there. Suicide involves dynamic and individual interactions. So, and again, the chart had the domain. This has a little of that. International issues, national issues related to economic disparities, media portrayals, policies related to lethal means access, healthcare access, community healthcare access, employment rates, family relationships, individual dynamics. So again, multiple things interplay together for the risk of suicide. So in the United States is the 10th leading cause of suicide, of death, with 14.2 deaths per 100,000 people. That rate alone doesn't tell you how serious the problem is, because even though only thousands of people die, almost 50,000 by suicide, millions think about it. So in 2017, 10.6 million American adults seriously thought about suicide. 3.2 million of them made a plan, and 1.4 million attempted it, but 48,000 died. So you see the numbers there, that going from suicide to actually dying from it, there's a steep drop off. And what our job is to try to reduce as much as possible, the numbers of people who start off at the beginning and definitely will end up dying by suicide. And it's estimated that one suicide affects about 135 surviving individuals. And here's the age-adjusted suicide death rate. Again, you've seen versions of this chart before earlier, and it shows you from 99 to now, the adjusted rate for men has gone up from somewhere around 18 to like 23, and for women from about 4 to about 7. So while women is still significantly lower than men, it's gone up at a faster slope than men had. And as I alluded to, when I started my medical career back in '99, the suicide rates were around 11, and it stayed around that 11 for 10 or so years, and then it's been creeping up, and now it's about 14 plus. So the rate increased on average by about 1% per year from 1999 through 2006, and then by 2% per year from 2006 to 2017. So meaning the rate of increase has gone up more in the past 10 years than it did in the 10 years previously. That's concerning. For males, it went up by 26% from 99 to 2017. That's from 17.8 to 22.4 deaths per 100,000 people. It did not significantly change from 99 to 2006, but then increased on average 2% per year from 06 to 2017. So again, that 99 to 2006 is probably why the curve was so flat around 11.1 deaths per 100,000. For females, the rates increased 53% from 4.0 to 6.1 from the period of 99 to 2017. And the rate increased on average by 2% per year from 1999 through 2007 and by 3% from 2007 to 2017. So as you can see, the women rate have been increasing significantly more than men over the past 2 decades, but they still have quite a ways to go. But at this rate, over time, 50 years or so from now, we may see more women dying by suicide than men. And so suicide rates for females aged 10 to 74 were higher in 2017 than in 1999. And the next several slides will show you that for women, the highest suicide rate was in the 45 to 64 age group, both at the 99 and 2017 time points. And over time, the suicide rate went up for every women age group except for those 75 and over. And as I said earlier, something has happened that the 75 and over death rates are dropping. And if we can figure out what's happening with that population, maybe we can translate it to we younger folks. And so this is a graphical representation of that, of how the rates have gone up over time. The blue is 99, the green is 2017, and you can see over time they've all gone up, and the highest rates are in the 45 to 64 age group. For males, again, suicide rates for males were highest for those age 75 and over, and then they're higher in 2017 than in 2008 than they were in 1999. And the rate for the males 75 and over, just like in females, is lower now than it was back then in 1999. And you can see that information right there in the chart. And also, rurality of where you live affects your suicide rate, believe it or not. So the age-adjusted rate for suicide has gone up significantly more in the rural parts of the country than in the more urban parts of the country. And they both went up, but the rural rate went up even more than it did in the urban areas. And so you can see the large central metro, which reflects the most urban parts of the United States, which is green, and then the, whatever color that is, the pinkish lilac is the non-core is a more rural area, and the gap between them has increased over time. So summary, age-adjusted suicide rate has increased 33% from 1999 to 2017, from a rate of 10.5 to 14.0 per 100,000. Average increase in rates went from 1% per year in the first 10 years to now 2% per year. And in women, it went up from 2% to 3% per year. For men, there was no real increase 99 to 2006, but it has been going up 1% a year since. And suicide rates were higher for males and females in all age groups from 10 to 74, and dropped from 75 and over for both males and females. And rural county rates increasing faster than urban counties. I'm going to talk some about veteran population, including them in my comparisons now. So about 46,000 Americans died from suicide in 2017, including just a little over 6,000 veterans. The number of veteran suicides have exceeded 6,000 each year from 2008 to 2017. Among U.S. adults, average number of suicides per day rose from 86.6 in 2005 to 124.4 in 2017. And these numbers include 15.9 veteran suicides per day in 2005 and 16.8 in 2017. And in 2017, suicide rate for veterans was 1.5 that of non-veterans, after adjusting for population differences in age and sex. And firearms were the method of suicide in 70.7% of male veteran suicide deaths and 43.2% of female veteran suicide deaths in 2017. There are also other deaths that aren't included in the veteran deaths. And these are 919 suicides among never federally activated former National Guard and Reserve members, which is an average of 2.5 suicide deaths per day. So American suicide deaths went from 31,600 in 2005 to 45,300 in 2017. And the veteran rates went from 57.87 to 61.39 in that time frame. Veterans account for about 13.5% of all deaths by suicide, only 7.9% of the U.S. adult population, whereas in 2005, 18.3% of all deaths by suicide and 11.3% of the U.S. adult population. So the veteran population is over accounted for in the suicide deaths. So this is a graphical illustration of what I was talking about. You can see the suicide rate has gone up for U.S. adults. It's also gone up for veteran population. But note, the U.S. adult population veteran rate went up 43% from 2005 to 2017. But the veteran suicide rate is only going up by 6%. So the veteran suicide rate actually is significantly slowed compared to the rest of the population. So that's not what's driving the increase in American suicide rate. Again, which is something else to worry about, that we really need to get to better understanding of what's driving suicide rate. And this here just shows you the numbers. Average deaths per day for veterans from 2005 to 2017 ranged from 15.9 in 2005 to 16.8 in 2017. The lowest there is 15.6, the highest is 17.2. So it's been relatively stable. I know in the past you'd heard the statistic of 22 veterans per day or 20 veterans per day. And what happened is in those numbers were included people that were not really veterans, and the VA is doing a better job of taking them out of the mix now. So included in those were never federally activated reserves, or members of the National Guard, or active duty. So those three groups of people that aren't veterans by legal definition, Title 38 of the federal law, were included, and now the VA has separated them away. So people who are veterans by federal law that qualify for veteran benefits is about 17 a day, which is generally held steady for most of the past decade. And I've talked through this before about the rate of increase in suicides. U.S. population has increased by 17%, veteran population decreased by 18% from 05 to 17, and increase in suicide rates for the population as a whole went from 14.7 to 18, and for veterans went from 18.5 to 27.7. The change for veterans in suicide rate from 16 to 17 is not statistically significant. However, the change in the rate from 05 to 17 is statistically significant. And veteran suicide rate is 1.5 times the rate for non-veteran adults after adjusting. The highest suicide rate in 2017 for veterans was in the 18 to 34 age group, different than the rest of the population. And it increased by 76% from 05 to 17. So these are young people that are killing themselves. So that is concerning. The lowest suicide rate, surprisingly so, is the 55 to 74 age group. So they have the highest count, but they have the lowest suicide rate. But the highest rate is the younger people who are just coming back from tours of duty. And so the absolute number of suicides is highest among veterans 55 to 74. They accounted for 38% of all veteran deaths because that's the largest group of veterans in America. But they didn't have the highest suicide rate. That has changed over the past 5 or 6 years to now be the youngest group, which is why there's a lot of attention being paid to those young guys and girls coming back in. So women veteran population increased by 6.5% during this time frame, and the suicide rate of women too has gone up significantly over time, such that the rate of suicide among women is 2.2 times that of a non-veteran woman. So the influence of being in the military on suicide is higher for women than it is for men. Part of that, we think, again, is because military veterans are more likely to use firearms. So women veterans use more firearms than the general civilian population. So they're more successful when they attempt suicide. For males, the difference in suicide rate is only 1.3. So women account for why it's up to 1.5. So something, again, to be concerning for us to think about as we look at interventions that our women veterans require special attention to help make sure that they're not dying by suicide. So I have some graphical numerical data points that show you this. So what I just said in words is right there on the screen, easy to grab and take. So the rate of suicide 2.2 times higher among female veterans. For men, it's 1.3 times higher among male veterans. Males 18 to 34 have the highest rate of suicide. Veteran males 55 and older have the highest count of suicide. About 70% of all veteran suicide deaths come from firearms. So there are 17 veterans deaths a day on average, 2 to 3 never federally activated former National Guard and Reserve members, and 1 current service member. So the latter 2 group of people, they're not veterans by federal law, by Title 38. But in the past, the VA had counted all those people, so now doing a better job of separating, so you know that. And this shows you of the veterans, of the 17 veterans or so that die a day on average, only 6 had been seen in the VA within the past 2 years. 11 had not. So most people who die from suicide on a daily basis that are veterans are not actively within VA care. So one interpretation of this data is getting into VA for care is protective of veterans. Most veterans, about half of veterans use the VA. So we think if we could get more veterans into the VA, we could probably save more lives. And this slide shows you the difference between the rate and the absolute count. So on the left, it shows you the absolute count, the total number, and you can see the total number of folks who died. The highest number is in the 55 to 74 age group, followed by the 35 to 54. But if you look at the percentage rate, the highest rate is in the 18 to 34, then followed by the 35 to 54, then the 50, then the 75 plus is higher than 55 to 74. But if the trends that we've been seeing, that the rates are dropping for people 75 and older, in 5 or so years, I can imagine the 75 plus age group for veterans to be the lowest rate too. So, suicide methods for veteran deaths, about 70% were by self-inflicted firearm, while 48% of non-veterans used firearm injury. And for male, it was 71% of veteran deaths, and for female, it was 43% of veteran deaths. And this shows you across the civilian and non-civilian population, the method of death. So you see for, let's look at males. So the veteran males that use guns is 69.4%, of non-veterans is 53.5%. So a significant gap in veterans using guns, which again, all by itself would explain the difference in the outcomes of fatality. Look at females. Female veterans, 43% use guns. Female non-veterans, 31% use guns. Again, you can see the gap there, and they'll be more likely to succeed. Poisoning is next, and suffocation. Suffocation is the second highest way people attempt to die in overall population, and then other captures a variety of many different things. So here's the veteran suicide rates put all together again in the graph, saying the same thing I've said. That you can see the 18 to 34 age group having the highest suicide rate. Here's suicide among never federally activated, and the National Guard has been rising, and the reserve members has actually dropped some. And it's the whole literature into this is fascinating. That's a talk for another day, as to, because we speculate that the reason why suicide is high among veterans is because they've deployed and stuff. Well, suicide rates is actually high among people who never federally deployed, people who never went to battlefield. Their rate is just as high, even though higher than the people who went there. And that's very fascinating to look into what happens, that something about being together and then disbanding back into society and not getting the recognition other people get who served, or not having access to the same healthcare because they don't qualify for veteran benefits and those kinds of things. So that in itself is fascinating and a topic of research down the road. Unfortunately, I don't know who's going to do that research because they're not veterans. So the veterans Affairs is not really looking into that, but understanding every aspect of suicide in different populations will be important because, again, it's different groups, different explanations, different interventions, and we have to try to understand each group so we can make a change that might make a difference. And you can see suicide rates among women veterans way higher than that among non-veteran women. And so talk about Alabama briefly. So Alabama veteran suicide death is not significantly different from the national veteran suicide rate. So I've heard all kinds of stories. I see all kinds of stuff quoted in the media, but the reality is we have a higher veteran suicide death than just the national average. Veterans kill themselves more than civilians. That's true. Alabama is no different than the rest of the country, but our rate is really no different than the rate of veterans in any other state. So we don't have a particularly worse epidemic than other states. And in 2017, the estimate was there were 124 veteran suicides in the state of Alabama, about 120 male and about 10 female. When the numbers are this small, they try not to break them down because they want to make sure people can identify individual folks. And so I'm going to pivot to the next part of my talk, which is about the effect of coronavirus, SARS-CoV-2, on possible suicide rates. So this is a 3D representation of the coronavirus. And by now, I think most everybody knows that COVID's damage is not limited to the lungs alone, that it's a whole body disease. And the brain is also a target of what the virus does and the effects. So as hopefully I've convinced you over the past couple of hour and a half or so I've been talking, that suicide rates are historically high in the United States now. Before we even met this horrible thing called COVID, life was tough enough. They've been rising over the past 2 decades, and it's the highest age-adjusted rate since the times of the Great Depression. That's kind of depressing, really, that we're comparing times now with 1941. And the United States is a lot richer. People live a lot longer than they did back then, but yet suicide rates are as high as they were back then. Again, I keep saying this so we know there's a lot to think about because there's things going on we don't quite understand that must be contributing to this, because prosperity alone as a nation clearly isn't helping address suicide rates. So we've got to make interventions to address and reverse that trend. So it's within this context of elevated suicide rates that COVID struck the US. And the things we've done to help keep us safe from COVID, like I'm alone in this room with 2 good people, don't have a full room of people. Most of you are watching me from the comfort of your offices or your homes or wherever you are. So we're taking unprecedented action. Things like this haven't happened since World War I, going back to another wartime during the Spanish flu. It's fascinating. I've been reading historical medical works and looking at pictures of people wearing masks in San Francisco back in 1918. Just the debates in the papers back then, which echo the debates now too. So this isn't really new. It's just most of us weren't alive during that time. But thankfully, papers survive, and you can go read the New York Times from April 1918, and you can see the kind of debates. They closed the schools down, they closed churches, the same things we're doing now. So medicine has changed, but it doesn't really change that much, because public health principles are the same through time. Until you have something that can cure a disease, the same principles of separating infected or possibly contagious from others and doing what you can to limit transmission is where we're stuck. And so while all these things limit new infections, it can cause adverse outcomes such as suicide risk. And I'll talk through some of the potential ways you could do that. So some of the countries that were hardest hit early on, I've talked about some of the suicides they've had, but mostly we talk about COVID-related deaths. Italy, for example, the first known pandemic-related suicide happened in March when a patient who had pneumonia jumped out of the window while he was awaiting test results to see if he was infected. And then there have been other suicides among frontline healthcare workers, and I'll talk about one when I get to physician suicide. People waiting for test results, and people affected by coronavirus-related bankruptcy. So previous studies tell us things that can be instructive during this time. So looking at trauma in previous disasters, including SARS, which is the older sibling of SARS-CoV-2. The 2011 earthquake and nuclear disaster in Fukushima, Japan. Both those studies showed significant rise in suicides during the emergency and after, in the months that followed. And in SARS in particular, most suicides involved in Hong Kong, so there's a cultural context to that, but it involved elderly or chronically ill people who were afraid of becoming burdens to their families because they were infected. Something some people have mentioned during the COVID time. So there's a nice article that I referenced here that looked at what kind of things might happen with the public health restrictions we've had to undertake. So I'll go through them one by one. Economic stress. So we've had a lot of business closures, lost jobs, shutdown of most public events. There's a fear of a new economic recession. I think we're technically in a recession. I think we've had 2 consecutive quarters of negative GDP growth. Much of the world is in a depression, for sure. And so that's pretty scary. And we have data, as I talked about in the first part of the talk, that looked at different parts of the world, that economic downturns often are followed by increased suicide. And the uncertainty around this current downturn probably will trigger more deaths in the future. So here's a graph that shows you association between income inequality and suicide rates in the United States. And you can see it matching up. As the income inequality increases, suicide rate goes up. So I have some headlines just showing you. Coronavirus may worsen symptoms in children with anxiety. Nearly 1 in 5 Americans say they have had a physical reaction when thinking about the outbreak. Most kids that were surveyed in this survey show their mental health has gotten worse with coronavirus. Signs of distress related to COVID-19 in the United States. 1 out of 4 people in this survey reported binge drinking at least once in the past week. 1 out of 5 reported taking prescription drugs for non-medical reasons. And 1 out of 7 reported using illicit drugs. And in this study that the Census did, Census was actually capturing data on depression and anxiety using scales. They found that 34% of folks showed symptoms of anxiety, depression, or both. And so 20 showed both symptoms of anxiety and depression, 4 showed depression alone, 10 showed anxiety alone. And that's double what was found in 2014 when they did this last. And the groups that have been hit harder than others include younger adults, women, and the poor. And this is notable because younger adults have been less likely to get seriously sick or die from COVID. And this shows you data point 2013 to 2014 versus 2020 to show the increase in people experiencing depressed mood. It went up from 25% to 50%. So significantly affecting the way people feel, as you can understand this time. Lots of people say the coronavirus has had a negative impact on their mental health. And you can see it there. Male, female, white, black, Hispanic, parents of children, not a parent. Across all groups, there have been significant effects on people's well-being, sense of well-being, and sense of who they are. Social isolation is something else COVID has done. How many of you have family members or friends or loved ones you haven't been able to see during this time because of COVID? You know, major theories of suicide tell us that social connections, social connectedness plays a key role in suicide prevention. People experiencing suicidal ideation may lack connections to other people and often disconnect from others as suicide risk rises. Suicidal thoughts and behaviors are associated with social isolation and loneliness. Therefore, from a suicide prevention perspective, it's concerning that the most critical public health strategy for COVID-19 is social distancing, that you keep away from people, you keep away from loved ones. And one of the saddest things about this is people are dying alone. People in nursing homes, people in hospice or palliative care, especially at the beginning when the disease was spreading like crazy. This picture, pretty sad to me. You know, this lady greeting our elderly one through a barrier. At least they found a way to greet and connect with each other. And people are being creative now in care homes about having ways to visit, maybe building plexiglass barriers outside, having transparent windows that people can talk through, things like that. But it seems like we're going to be in this posture for a while. So finding ways to connect with those who are vulnerable, those who are alone, is going to be important. Look at this. I'm sorry I can't kiss you. Coronavirus victims are dying alone. That's one of the saddest things about this pandemic, that people are dying alone. It reminds me of when HIV started, when people would die alone. And this is another pandemic. It's the HIV of this generation, because I came into medicine when we were finally beginning to figure out HIV and develop medicines to stop HIV. So I'm hopeful that I will see this, and the medical students and residents graduating now will be able to talk about this in the future, how they were around when we figured out how to conquer coronavirus. Too. Another thing that happens with this illness is a loss of community and religious contact. I physically haven't been back to church since March. That's the longest period in my lifetime that I've gone without going to church. I don't think I've ever gone more than a month without going physically to church. Of course, I'm doing this online now, virtually, but I heard a statistic from a preacher this weekend that in the United States, about a third of Christians haven't gone to church in any way, shape, or form since it started. That's a lot of people. People who find meaning and derive value from being part of a connected group, losing that. And we know, again, that one of the protective factors for suicide is being part of a religious, ethnic, or social community, being able to attend regular events, including church and the rest, being able to have birthday celebrations, weddings. My wife threw away a wedding card we got last year that was for, what's the holiday, May? Memorial Day weekend. Didn't happen. They postponed it till Labor Day weekend. It's not happening. So now they're postponing it to next year. Just think about that people are having milestones in their lives being altered. My daughter didn't get to have a prom as she graduated from high school. Fortunately, we were able to have some type of graduation. But just think about all these things that have meaning, that like a once in a lifetime thing that you can't get back. You know, you graduate from high school only once. Hopefully, only once. You do your senior prom, you do those things, and to miss those things have meaning in people's lives. And over the past several months, we've postponed all this. Life goes on, but we're postponing meaningful things in our lives. And for many people, that can be a source of distress. And so the idea that we don't connect with others the way we did before, that we don't have the same social, community, religious, whatever it is, expression, definitely makes one worried about people who are going to be left behind, who are going to be left alone, who aren't going to be part of a community, who aren't going to have someone to ask after them, that they'll be isolated and the risk of suicide will go up in that group of people. Barriers to mental health treatment. So over the first several months of this, we know that hospitals reduced their availability for things except for the most important, the most urgent care. And mental health services clearly will not be at the top of many people's list. So mental health services are already hard to access in most places. Mental health beds are a fraction of what they were in the 60s before deinstitutionalization happened. And so hospital emergency rooms continue to get overcrowded, and it will discourage many people from getting help they might otherwise seek. Suicide hotlines and telehealth services were getting increased demand, and wait times were getting longer. So sometimes it means people who might need help, including frontline healthcare providers, couldn't get the help they needed in time. Social and media influences. Back to the topic of the media again. If you watch the news, if you get on social media, you'd see all these stories, all this news about COVID and everything going on. And you can imagine people becoming depressed and angry at this thing dragging on and on and on and on. Firearm sales also went up. So this is all a perfect storm. All these things, all individually and collectively together, synergistically happening at the same time. So gun sales have increased significantly in the United States. And as I've talked about before, access to firearms is a major risk factor of suicides. So the number of suicides is going to go up because people have more access to firearms. And increase in alcohol use, something else to it that's increased dramatically. The sale of alcohol is up the roof. And so heavy drinking increased. So in North America shows consumption and sales increase. And in many states, alcohol was designated as an essential service. So that's one of the things you could go out and get. So guess what people are going to do? Don't go out and get alcohol. You see the college kids on TV. You see, my daughter's at the University of Alabama. They've been on TV so much the past week. You know, my old town, Columbia, I saw University of South Carolina on TV too. In fact, I don't think there's a school, maybe the Ivy League schools, but other than that, I don't think there's a school I haven't seen on TV where the kids all have bottles and all hanging out together, doing stuff. And you know, people are going to make bad choices with alcohol. They're the lubricant that can lead you to do things you wouldn't ordinarily do. And about 30 to 40% of deaths by suicide involve alcohol. So you can imagine, again, putting all these individual things in there, that something bad is going to happen eventually for many people as a result of this. Furthermore, long-term use of alcohol can cause alcohol use disorders in some people. And so, and something to be worrisome about. So here is a graphical representation of what's happened since COVID. Look at what happened after 9/11. The gun sales didn't really go up much. Virginia Tech didn't cause any kind of spike. Obama elected caused somewhat of a spike. Sandy Hook caused a real spike right there. And then you see San Bernardino, you see Pulse, you see, but then look at COVID. COVID is as high as Sandy Hook. So that's an amazing thing. I'm not sure what the relationship of guns are to COVID, but it may be the same as a relationship of tissue paper to COVID, because couldn't figure out why we couldn't find tissue paper in the stores. Can't explain why paper towels are also meat. God let us have meat again someday. You know, some things, maybe somebody smarter than me would tell us 20 years from now, this is why that happened. But you just see the most unlikely things just disappear from the stores. And so guns were one of them, along with alcohol. And you can see here again that the coronavirus outbreak mirrors the Sandy Hook shooting in terms of people buying guns. Then I think the worry was there's going to be a crackdown and the government was going to stop people buying guns. I'm not sure what the theory is behind the current buying of guns, but again, maybe we'll learn that in time with future studies. And look at the alcohol sales, up 30%. Wine, spirits, 3-liter boxed wine. Now you're talking about it. You know, people buying. I don't know. Can you buy alcohol in the mail? Yes, you can. So people doing boxed orders from Amazon and stuff. Look at online sales went up 42%. So people stuck at home. What else are you going to do, right? Other medical problems. Also, during this time when, you know, routine access to care was restricted, meaning people have to wait longer with symptoms, some things get worse, pain might get worse, and you can already imagine that people with chronic medical problems, you know, myself and my good man here in the studio, we're talking during the break we had about medical problems, pain, and suicide. And this is one of those things that over the period of time you tell somebody, wait, we'll reschedule your appointment 6 months from now. You don't know if the medical problem is going to last 6 months from now. You know, even if objectively, psychologically, it may seem like you give up on them. People might go, they don't even care enough about me to see me now. I'm just not going to wait that long. So all these things can all add together. And we do have some opportunities, though, even in the middle of all this, to do certain things to help us with suicide prevention. So even though the term is social distancing, I want to emphasize it's physical distancing. It's stay 6 feet plus away from people, gather in open areas if you can. So you should not socially distance, meaning you should stay socially connected to people. You should call, you should FaceTime, video chat, reach out to friends, email, send a letter. Everybody make the commitment. Think about a friend you haven't been in touch with for a while. Reach out, check on them, see how they're doing. You know, I've been trying to do that a lot over the past several months, intentionally doing so. But then one person I thought of writing, my biology teacher in college, I didn't get around to writing to her until I found out she was dead, which makes me feel bad. I really tried, but I knew I should write her because it'd been a while. But then I got an email from another teacher to say she died. And so reach out. Think of somebody you're fond of, but you haven't been in touch with for years. Just reach out and say, just checking on you, because you never know how people are doing, and you never know that making that connection, maybe your touch, you're reaching out, maybe what makes that person feel valued. So reach out and touch somebody there. We can use telehealth as we're doing teletalk right now, doing telehealth visits with our patients to provide care. The VA has a free app that I'm plugging here. It's called the COVID Coach. You can download it. You can Google COVID Coach and find it. It's on the PTSD VA website. And it has information about coping during the pandemic, tools for self-care to improve your emotional well-being, trackers to track your mood, and graphs to visualize progress over time. Then there's distance-based suicide prevention things. For example, telephone-based outreach, caring letters intervention, which is just sending a letter to people who've been in the hospital. Amazingly, something that simple. Dear Mr. or Miss or whatever, you were in the hospital, we just wanted to check in to see how you're doing. We want you to know we care about you and we hope you're doing well. Something that simple reduces suicide rates. Amazing. Something that simple, just writing a letter to everybody who was in the hospital or who was in the ER and seeing for suicidal stuff. So while we like to think of fancy, complicated interventions, there's some simple things we can do, healthcare providers and healthcare systems, to make a difference. So I saw a news report on CBS months ago on the psychologist who first came up with this concept in the 60s or so, and people poo-pooed it. And now his family goes, he was right. He knew something about it because he just personally decided to write every patient he treated in the hospital. And he thought he saw a difference. But now we have evidence from studies that say, yes, just a simple act of writing letters can make a difference. Some things that make you optimistic during this time, that suicide rates don't actually have to go up despite all of this. After 9/11, suicide rates actually went down because people pulled together. So crisis, they say the ancient Chinese character for crisis is also the same for opportunity. In a crisis, there's opportunity. People can come together and support one another, or we can pull apart. So we're at a crisis point as a society, as a country, as a globe. Maybe we can find ways to pull together. The fact that I can do this talk, and as I'm told, there's people in New York watching me that I probably will never meet and they'll never meet me, that's something pretty cool. I met with a colleague yesterday by Zoom, and she was telling me how Zoom has changed things so much that now you can take part in grand rounds around the world. You can access things you never would. They were around, but it wasn't that widely broadcast. So if you couldn't travel somewhere, you just kind of assume you couldn't do it. Now, travel isn't part of it. Just give me the link, I'll go join it. So you can connect, you can meet people, you can make friends, you can do things. So technology and stuff might make some of this stuff not as scary as it is and connect us in different ways. So it's up to us as a society to find ways to come together to address some of this. So I'm going to talk briefly through some ways in which we can attack suicide using a recovery-oriented practice model. That what it is somebody is in a clinical state that they're vulnerable for suicide. So effectively, that's emotionally, motivational, cognitive, behavioral. Something is going on that puts them vulnerable at that particular time. And the red arrow goes to suicide attempt or completion. What you want to do is intervene to get them back to baseline or recovery. So that's the way we postulate the theory from wellness to death by suicide. People have tried things like no suicide contracts in the past. But the reality is they don't really work. I was taught to use them as a medical student, but by the time I was a resident, it was apparent they didn't work. Because all it does is it tells the patient, do you agree if you're going to kill yourself, you're going to call me? Sure. Of course you're going to say sure. Just let me out of your office. And that's what it is. I mean, people who do that. Plus, it doesn't offer you medical legal protection. It doesn't do you any world of good in court. So if you think that helps you, it doesn't. And providers think because the patient signed and said, yeah, I'll do it. It doesn't do anything to help you. So what helps instead is safety planning. Safety planning is a brief clinical intervention that follows risk assessment and helps you prioritize strategies. So this involves you and the client sitting down and talking about things you can do to help protect you should you get in this. So it's a hierarchical list of coping strategies that patients can use. So what you do is, you walk through like, hey, These are my warning signs. When I start to get sad, when I lock myself in my room, when I start to drink past 4 a.m., something like you. So the patient writes those down. Then number 2 is, what can I do internally to cope with that? Well, I think about my favorite ball game, or I remember my dad and how we used to hang out. So the person writes down what their coping strategies are internally. The next one will be social situations and people that will help you distract yourself from that. So say, well, calling my girlfriend, or going to the park, or something like that. Then the next thing is people I can ask for help, and they list people they can ask for help. And then the last part is professionals I can reach out to as well, and things I can do to make the environment safe. So you have the patient do this before they get their crisis, because people don't think, well, in a crisis, it doesn't matter what the crisis is, the decision point of an attempt for suicide is a crisis point. So you want them to have this. So if they paste it in places, the refrigerator, phone, TV, in front of the gun safe, wherever, so that they can look and see what they thought about. They thought about it, they wrote it down, and say, well, let me try these steps. And it's been shown to help reduce people's completion of suicide. So that's empirical, much better than the no suicide contract, because it actually involves the patient. They think through it, they come up with plans. And so the steps, and I talked through that already. And so talked about why firearms are so deadly. And that's because when people use firearms, about 90% of the time, they die. If people use other methods, only about 5% of the time do they die. So even if all we did was switch people from using firearms to other methods, the lethality would drop just by that math alone. That regardless of the intent, the fact that they're not as fatal means you're going to save lives. So that's an important take-home point. And so because we know people like their guns and are attached to guns, trying to get people to get rid of guns is mostly a fool's errand. What we can do is use principles of lethal means safety to talk through people about how you can separate them in time and space from being able to have a loaded weapon at the time they're in a crisis. So what you want to do is work with people, work with gun advocacy groups, work with whoever to teach people about safe storage. So what examples include temporary off-site storage during high-risk periods. So like California and some other states out west, I don't know if there's any states on this side of the country, have, I forget what the name of the law is, but when somebody is at risk of suicide, the family can petition the court to take away their guns away from them during that period of time they're at highest risk. What we're thinking is anything that can separate the time and space between when I want to do it. Have you ever been in traffic where someone really made you mad and you're thinking, if I had a gun, I'd just shoot them? I mean, it's kind of scary because I think I'm a normal person, but sometimes people make you so mad and then you go, that's what it is, because sometimes we have instincts and impulses and thoughts, and for most of us, what allows us to be part of civilized society and not get in trouble is we're able to control our instincts. Sometimes people can't, and so however you can help people control that is what you need. So if your gun is locked, you have to unlock it to kill yourself. If it's unloaded, you have to load it to kill yourself. Every extra step you put in there gives that person time to think about it, or it gives somebody else time to interrupt them. So that's what the concept of lethal means restriction is, to help separate time and space. So here's a hierarchy of safety options to consider. So temporary off-site storage, or secure the firearm someplace where lock them up in the safe, give the key away, or use a gun lock, meaning you have to undo the gun lock. Maybe temporarily disable the firearm, remove the firing pin, disassemble, lock, anything, again, that can separate you in time and space. And I gave you this statistic before, but firearm ownership is twice as likely to result in suicide and homicide. Important take-home message. If you have a gun, you're more likely to use it to kill yourself than you are to kill somebody else. And the most common victim, if you kill somebody else, is somebody in your family. And so think about how we can make firearms safer for people with firearms. And there's more information available, meansmatter.org, Take Calm online, and so information about how to have firearms and reduce suicide or homicide. So the last part of my talk now is going to be about physicians and suicide. So this made the news. This was very sad when it made the news. I think this was back in April. Top ER doctor who treated virus patients dies by suicide. This is Dr. Lorna Breen, ER doctor in New York, accomplished lady, done well. She got infected by COVID. She recovered, but then her family says she was never the same again. Her sister says she's sure the virus affected her brain. She was treated for depression, but just never seemed to recover, and she ended up killing herself. So we know already healthcare professionals have higher suicide rates, and now in the middle of COVID, healthcare professionals are being asked to work incessantly. I haven't really taken vacation since January. I'm going to fix that in 2 or 3 weeks. But there's lots of people like that that haven't been able to because we've been needed in caring for our patients. And there's concerns about how our well-being is. So there's a couple of helplines and support groups available 24/7, staffed by physicians and other healthcare professionals, and I have some of those links on the website. Every year, before COVID, about 400 physicians are thought to die from suicide. Male physicians are 1.4 times more likely. That's like the same as the veteran rate. Female physicians, 2.27 times more likely. Again, about the same as the veteran gap. And burnout across the physician population is thought to account for some of this. Medical students also seem to have high risk of burnout, substance abuse, depression, and suicide. And about 30% of residents in one study were estimated to have significant depressive symptoms. Another one found 24% of interns had suicidal thoughts within 3 months of starting training. That's scary. Yet doctors are less likely than other people to seek mental health treatment. And I talked about this earlier in response to a question. Why don't we seek help? Silence. We rationalize that, hey, we're caregivers. We can't look for help. And we think we're supposed to stand up, man up or woman up and just work through it. Sleep deprivation, student loan debt, all that stuff makes you feel like you can't make a mistake, you can't ask for help. You just gotta keep going. And it's hard to get care, I can tell you that. Confidentiality concerns, people are concerned. If people in your hospital find out you're getting help, would anyone want you to be their doctor? What would they think of you? Time, because doctors notoriously don't have time. To make time is hard, and so you just got to keep working. So that makes it difficult. And then some people aren't sure treatment would help. And then, even though physicians are subject matter experts in a lot of things, they may not know everything about suicide, and they may have outdated ideas and stuff about things. Also, though, the structure of medicine, the nature of medicine is such that many places seem to negatively penalize you for seeking help. If you look at licensing questions on boards, they ask you if you've ever been treated for depression and anxiety. They don't ask you how you're functioning, which is what matters. They don't ask you if you've ever been treated for asthma or hypertension. Why ask you if you've ever been treated for depression and anxiety? They're telling you that those things are different. And we as doctors need to fight that. Those in licensing boards and the rest need to consider the message they're telling doctors when they're telling you that you have to disclose when you seek help for mental health problems, but not for physical problems, rather than a generic question. Do you have any medical disorder that impairs your ability to function? That's really what matters. It doesn't matter what the name is. And so lots of doctors don't want to say anything because they don't want to lose their license. That's what they do. And so here's a laundry list of things that might increase physician distress, and I'm sure my physician colleagues would say, yep, electronic health records, they're supposed to be a time saver. It never happened, never will, until Apple does what they did with the iPhone to that. Never happened. Paperwork, bureaucracy, lack of autonomy. I mean, you could just go on and on and on. There's lots of reasons why doctors feel overwhelmed. But if you don't seek help, sometimes it catches up with you. And physicians who die by suicide, in one study from the CDC, showed that physicians have 20 to 40 times the rate of benzos and barbiturates and antipsychotics as other people, which means doctors are treating themselves. And pity the fool who has themselves for a doctor or a lawyer or a client, because that means you're not objective. Again, the ability to think clearly is not there. You may be the smartest doctor on the wall, but not necessarily when it comes to yourself. Having somebody else help you allows you to be more objective. And doctors are able to use poisoning. Doctors actually know how to kill themselves because they know how the drugs work. And female physicians succeed pretty well. I think the death rate in female physicians is much higher than in non-female physicians because they know what drugs work. If they're going to take overdose and stuff, it's going to be enough to kill. Part of it may also be because doctors are repeatedly exposed to trauma, so the fear of death isn't there like others may. So what can we do? Stigma reduction, make it acceptable as a culture, as a medical culture to seek help, policy changes that allow us to have a safe, supportive culture and encourage rather than penalize seeking help, safety net and employee wellness programs, promoting self-care, addressing burnout, addressing our own physical and mental health need will allow us to remain highly competent and resilient, shifting the lens to focus on mental health, so we only don't ask about physical illnesses, but mental health. How are you doing? During these times where lots of people are stressed, I can tell you, many doctors I know, it's just a stressful time. The past few weeks have been extremely stressful for me as my hospital looks at opening up more of the care we do to more face-to-face care. So I got to make sure we have enough COVID testing for everyone. So the surgeons and the anesthesiologists like, let's do more surgery. I'm like, that's great, but then you want me to test your people. I got to make sure I got enough tests. So it's been very stressful making sure I can procure those things. There's those kinds of things going on. So I'm telling people, pray for me, reach out to me, because I'm just as stressed as you are. So everybody should be reaching out to folks out there to make sure everyone is doing okay, because there's a lot going on during these times. For the people at the front line, for the people making decisions, for all of us are dealing with this thing in different ways. And hopefully in the end, we'll have a better, stronger, healthier physicians, better able to serve the needs of those who retreat. And this is my last slide. 400 US physicians take their own lives every year. Let's talk about it. Thank you for letting me speak to you twice today.